Testing one, two, three. All right, well, good evening to everyone. It is 7 p.m. and welcome to Coronavirus COVID-19 and Us, the Empower Hour. This is our fifth Empower Hour, the fifth live session that we've held, and we're thankful for all of the great panelists and experts who come to share their expertise, as well as the attendees. Again, we try to have this hour so that the public can interact with those who are frontline workers as we try to deal with a response to this pandemic. Again, all of us are, for the most part, sheltering in place, I'm sure. Hopefully everyone is staying safe, staying healthy, and of course, staying at home, sheltering in place, because again, we want to make sure that we're following CDC protocol, that at least we know that is consistent. As we hear so many and too many conflicting messages, at least we know the CDC has been very diligent in their communication, in their health messaging, to make sure we at least practice our social and physical distancing and making sure that we are sheltering in place. Which sort of segues into our conversation this evening, because there's conversation about us easing and relaxing the whole sheltering in place. And whether that's good, bad, or otherwise, that's what we're going to deal with this evening. Again, we know what the state of Georgia is doing as of Friday. Many of us are here in Georgia, even though we have some participants that are in Texas, participants that are in Kentucky, I see. My former colleague, Dr. Muriel Harris, is at University of Louisville. I see that she's with us, and she's actually going to be joining us as panelist on Thursday. And so she's associate professor there at University of Louisville School of Public Health. So we're appreciative that she's here. So again, as the ease is taking place on the restriction, we want to deal with that this evening. So we're glad that everyone is here to talk about it. We have esteemed panelists this evening. We have three guests, and then I'll do a small introduction. Of course, they will give you their opening remarks. We have, and I'm going to just call their names, and then after calling their names, I will let them come up one by one. We have Dr. Jasmine Ward, who I will say I met last year at the memorial service of Dr. Bill Jenkins. And since that time, we've had a kindred spirit, and I'll be the first to say that she's been, if there's such saying as a right-hand person, Jasmine would be that. Again, Jasmine has been very helpful in a number of projects that I've worked on. Again, I want to thank Dr. Ward for being here, and I'll let her talk in a minute. But then we also have Dr. Jennifer Edwards, Dr. Jen, who is in Dallas, Texas. Dr. Jasmine Ward is in Arlington. Dr. Jennifer Edwards is in Dallas. And again, we're going to let her present. She's a research scientist, and then she's going to talk about what she's been doing, given the epidemic. And then we have Interim Dean for the School of Public Health at Georgia State University, Dr. Rodney Lyn, who's going to, of course, share from that perspective as far as being at a public institution. And as we have to follow suit with our governor, how does that impact him and the work at Georgia State at the School of Public Health, being a public institution? And so we'll let him talk about that. So we're going to get right into it, which is what we always do. Of course, I'm Mike Weaver, I'm your host. I've been in public health for a minute in many different facets. We have one of our volunteers here, Rania Abdullah, who's down in Tampa. She's also a donor for the volunteer program that we have every summer. Rania volunteers with us as well as donates with a team volunteer program where we go to different cities and volunteer. So I've been doing that for a minute. I'm also a Hurricane Katrina researcher, which is sort of where this stems from. Again, I responded to Hurricane Katrina in 2005, and that prepped me for this, right? So I just said, well, I learned my lesson about how there was a lack of messaging after Katrina. And I said, I cannot let that happen again, given all of my academic training and personal training, if you will. So that's where I am, and I'm just glad that everybody is here. So we're going to do round robin. We're going to start with Dr. Ward and go from Dr. Ward to Dr. Edwards, and then we'll let Dean Lyn, give his opening remarks, but we're going to again start with Dr. Ward. And again, they'll have about 5 or so minutes, 5 to 7 minutes to talk about what it is that they're doing in regards to the pandemic. And then we'll open up to everyone. So without any further ado, Dr. Jasmine Ward.
Hi, so thank you all. Again, Mike, thank you so much for having this conversation. Honestly, what we are doing, I'm the founder of Black Ladies in Public Health, and we are a grassroots organization that really connects people who are interested in public health, people who are trained in public health, and certainly those who are in fields that are very highly connected to public health. We are online and communicating daily. We've been talking about the coronavirus since December. What we did not realize is that we would have to take such an integral role in helping to communicate with our communities. And so for a while we were kind of waiting, and it was like this waiting and see moment. And then we realized there were some things that we just had to do within our group. And so what we've been doing is trying to field questions and community solutions from our friends and comrades. So we are putting together graphic design projects that are really health communication to build health literacy in terms of what we're dealing with in coronavirus, with all the things that are changing and why they're changing. Not all the time, people aren't always informed as to why certain things are evolving, because they think we know, and then all of a sudden we change something. And so the confusion has led to a lot of mistrust. And so we know that health communications is really one of those ways that we can combat the mistrust there and provide information that people can use. We've been hosting check-ins every week, twice a week, to make sure that we are staying in tune with what is happening within the public health space in various cities, because we know that that's part of the confusion. Things are changing all around us, and sometimes it might not be changing for you. And so the concern is really that we are staying abreast of what's happening, especially with our public health workforce, because things are impacting them as well, us as well. And then one of the projects that we're working on is a data resource. So providing information about the race and ethnicity data across the states, understanding that there are limitations to the data that's currently available. And we put out a public link for that. And so I will put the link into the chat box as well. That has been one of the things that we've kind of followed along course of development, which states are putting out information and changing information and taking down websites, putting up websites. So we've been really active in following that information. Right now we have 42 states that are reporting race and ethnicity data at this time. Not all touch points. We are certainly trying to stay abreast of that as well. And lastly, we have put together a team of individuals who really have been impacted personally by COVID-19. And we have started a website called United Memories that will really serve as a memorial site for us in terms of a virtual memorial of those who we've lost. And so really taking the idea of every person, every data point, it represents someone, and those someones represent many people who love them. And so we have been really actively trying to just keep up with things that we know the community wants to see from us, in addition to being public health for public health.
Now, is there a website for United Memories, Jasmine?
Yes, it's unitedmemories.com.
Okay, pretty straightforward then.
Mm-hmm.
Straightforward. All right, wonderful. Okay, well, thank you for that, Jasmine. And again, we'll obviously interact with you more as we go on. And I want to now bring on Dr. Jennifer Edwards, again, a research scientist there in Dallas, Texas. Dr. Ward is in Arlington. Dr. Edwards is there in Dallas. So, Dr. Edwards, could you please tell us how you're responding and the community is responding to coronavirus there in Dallas?
Sure, thank you. So I certainly appreciate you having me on, and this is a very important conversation. So I am located just north of Dallas, and a lot of people are getting ready to hit the malls this weekend, which is somewhat frightening. And so a little bit of background about the work that I've been doing so far is that I serve in the capacity as a wellness advisor and also principal research scientist. And so the wellness work that I've been doing relates to reversing burnout and restoring balance. And that's been really important right now as we have people at home, working at home, and just really at capacity in terms of what they're able to do given work commitments and also family commitments. And so I've really scaled up that particular aspect of my wellness advisement work. And then as principal research scientist at the National Network of Public Health Institutes, which of course today I'm speaking in my own capacity, but we have begun leading a series of national conversations with our members, where our members are universities and public health institutes and nonprofits. And actually we have the Georgia Health Policy Center at Georgia State as one of our members. And we have been listening to what is going on in each state and what are the emerging issues and the concerns. And so we've talked about data, we've talked about equity. And so from everything that I've heard, because we hear from so many different sources, we hear from the news, we hear from the experts, we hear from social. I pulled together a blueprint. Dr. Weaver, I don't know if you have the link. If not, I can pull it up. But it relates to the potential priorities that we can consider in terms of COVID-19 evaluation, because we are going to have to evaluate these efforts, as well as collaboration and programs. And so there's overlaps in some of the areas where medical sociology, let me pull it in here just so that you all can see. Oh, you have it there. There's some overlaps where we have medical sociology topics. And these are things that I've either heard a lot of conversation around or even diverging opinions around, which means that there's an opportunity for collaboration and for research and for evaluation in these areas. So really, if we think along the full continuum of care between these medical sociology and equity priorities, we see that there's an example, an opportunity rather, to look into the socioeconomics of testing, symptomatic and asymptomatic, which both have their own dynamics. And then further along the continuum of care, where we're looking into not only testing, but treatment as well, and the morbidity stats and hospitalizations, which there are about 10 states that are represented in CDC's data on hospitalizations right now. So that will be an interesting story to tell. And we want to also consider, you all might hear my Chloe in the background. She's an activist in the making. She's with her dad. So you all might also want to consider worker safety as a priority. And there are inequities there. So we really have three core areas. If we try to pull together all these conversations where there are opportunities for programs at the state level and the local level, as well as collaboration opportunities and evaluation. So I look forward to having this conversation as we try to really intervene and step in and be part of the response. So thanks for having me.
All right, Dr. Edwards, thank you so much for that. And as we speak, I just put up the blueprint with the share screen that we just had. So that's the link for it right there. Again, we're pleased to have all of our guests, and particularly Interim Dean for the School of Public Health at Georgia State University. Everyone has very busy schedules, and Dean Lyn is as busy as the rest of them, if not the busiest. But that notwithstanding, again, Dean Lyn, we appreciate that you're here. Can you please present for us what's going on with Georgia State and the response that the School of Public Health as well as the university is giving coronavirus and COVID-19, please?
Yeah, thanks, Mike, for having me, and I'm happy to be here to talk to everybody. I think that, for us and for me, the initial response in, early to mid-March was really about how do we protect our students, our faculty, and our staff. And so that was the initial push that, really consumed a lot of time to move everything remote and online and virtual when, faculty and staff weren't necessarily prepared for that. So, we've been very pleased that we were able to do that and do it we haven't gotten a lot of complaints. I think everybody's just in a spirit of trying to work together and make this work. And so, We've done that for spring. For summer, we're going to be totally online for all of our courses. In fall, we're having that conversation now, but should know or have a plan regardless of what's going on fairly soon. So from a planning standpoint, that's what we've been focused on. And I've served on our university task force for preparedness. So that group had a real hand in our response. In terms of the School of Public Health, we have, you know, the amount of media that this has generated and requests for our experts to go out and talk about the things that we're doing around modeling. If you go to our website, we model a dozen countries and probably, you know, half a dozen to a dozen states to sort of project out, you know, based on mathematical models, what the infection rate is going to look like, what deaths are going to look like at any given time. So that's one of the things that we've been doing, and we have faculty that are really talented in that area. We've also been out there talking about health equity a lot, and the issues that communities of color are facing. It seems to me that out of the gate, because of our lack of knowledge about COVID-19 or really SARS-CoV-2, the virus itself, we had to impose a lot of blunt instruments, such as, you know, social distancing and stay-at-home orders and shutting down universities and schools and daycares. And the hope was that that blunt instrument would serve everyone equally, but what we know is that it hasn't. Those that are essential workers that, you know, have to go out and go to work and don't have protective equipment and materials are at greater risk. And we know that those are African Americans, Latino, and other low-income individuals. So we've got to look at that, and I think we're trying to bring attention to that in the School of Public Health. In terms of other things that we're doing, we're working with the State Department of Public Health and the Commissioner to take our graduate students, our MPH, PhD, and DrPH students, and provide them the opportunity to serve as contact tracers. And so just yesterday, I delivered a list of students to the department that had expressed interest and had been recommended by our faculty. And so we expect them to be called into service very soon. We've also been in touch with the DeKalb County Health Department. That's a local health department in DeKalb County, which is the third largest county in Georgia, and it's right here in the metro area. So we're contributing both at the state level as well as in the county. You know, for those that don't know, our university is majority minority. DeKalb County is also a majority minority county with close to 800,000 residents in it. So we're happy to be working with the state and the local health department. We're also fortunate to have a prevention research center at Georgia State. It was just established last year. We are really focused on migrant and immigrant health in a community called Clarkston. And so we have worked closely to do needs assessment in that community, help coordinate testing, and also on our website have really focused on communication. And we have materials around COVID-19 on there, and we have it in 12 different languages for the various subpopulations in the Clarkston community. So, you know, those are some of the things that we're doing, and I look forward to talking with everyone more about it.
Dean Lyn, let me just ask you quickly, what is a contact tracer for those who may not know what a contact tracer is?
Yeah, these are individuals that identify, once people have been identified as positive, they contact those individuals to notify them in many cases of their status, and then to gather information about where they have been and who they've been around, and really sort of look at the network and backtrack and reach out to those people so that they're aware of their potential exposure, so that they can self-quarantine, get tested, so on and so forth. So it's really a strategy that's really focused on containing the spread of COVID-19 as quickly as possible. one of the challenges with COVID-19, obviously, is that asymptomatic people are asymptomatic in some cases, and so they're spreading the virus and don't know it. One of our faculty members did the study on the cruise ship out on the West Coast and looked at all of the tested, the data on testing for every individual on the ship, and they found that 20% of people were positive but had no symptoms. So, that's one case, but right now we believe between 20 and as high as 40% of individuals are asymptomatic.
And that is a serious number, to say the least. That is a serious number. For those of you who are not in Atlanta, there's an assisted living facility in Southwest Atlanta where initially 5 deaths were reported, and when those 5 deaths were reported, 70% of the residents tested positive, and since that time, 15 more people have transitioned, have died from one particular assisted living facility right there off of Cascade, Arbor Terrace. And it's so unfortunate, again, but those were tested and were positive. But again, as Dean Lyn mentioned, there are so many who are asymptomatic that who are walking around and maybe, again, being in communication, being in contact more than anything with other individuals, and could possibly be spreading the virus, unfortunately. Well, let's do this. We always take about 15 and 20 minutes and do just that, have some opening remarks and allow for, again, the panelists to express what it is that they're doing in response to COVID-19. And we've heard from, of course, the 3 panelists that we have this evening. So what we, out of respect for what we do with the Empower Hour, we're going to open the floor to attendees. We have, several who are here that if you have any questions for our guests, again, we have Dean Lyn from Georgia State. We have Dr. Edwards, again, who's there in Dallas, just north of Dallas, Texas. And we have Dr. Ward, who's in Arlington, Texas, they're all here with this and coming with different aspects in response to coronavirus with local community. And so they are here. So if there's anyone who has a question or concern, I will unmute you and I will allow you to interact with our panelists. So you can wave, you can put your finger up, and or you can leave a question in the chat. And please, if you leave a question in the chat, make it short, right? Get me reading these very long. And speaking of the chat area, you'll notice that again, we put our disclaimer in the chat area, but we also put some articles in the chat area as well. Again, I want to thank Rania Abdullah, who forwarded some articles just hot off the press, just came out yesterday. One is from Dr. Reuben Warren. Again, just came out yesterday from out of Johns Hopkins, out their press. Dr. Warren was on our show 2 weeks ago. And again, so he's dealing with, he has a nice article. Again, I left a link for you that you can read the article itself, called The African American Petri Dish. Very interesting spin on COVID-19. And of course, written with Dr. Ron Braithwaite at Morehouse School of Medicine. Of course, Dr. Warren's at Tuskegee, but Dr. Braithwaite is at Morehouse School of Medicine. A very fine article. I would encourage you to read that. So we also try to make sure that we give you some great resources when you come to the Empower Hour, again, right off the press, hot off the press. And again, I want to thank Ronnie for forwarding that. With that, any questions or concerns from anyone that anyone would like to ask of our panelists? Okay, well, y'all are being shy. Let me ask now, Dr. Ward, you mentioned check-ins with the group that you're dealing with. Now, how often do you do this check-in, and how have you found that to be, advantageous for those who are, I think you said, future public health practitioners?
Well, actually, it's we started the check-ins just because there were individuals within our network who were impacted by COVID-19. Either they had COVID-19 or they had a family member, and so we were trying to keep up with folks in various ways and realized that it was probably best that we connected. We do Zoom calls like this every Sunday at 6:30. We then do a mothers and caregivers call that we do on Mondays at 8 p.m. 8 p.m. Yes. We have so many calls going on now. We do a student call on Wednesdays, and we started the student calls because we did have students who were kind of just not really knowing, they didn't really know what they wanted to do to support the efforts, but they knew they needed to do something. And so we're really trying to assess what they are interested in doing, what they're capable of doing based on their trainings. If we can have them kind of what Georgia State is doing in terms of connecting them with opportunities that seem to be quite appropriate for them being students at this time and entering into this field at such an important time in our history. And then we try to do our United Memory calls on, we're doing those now Monday before our 8 o'clock call. So lots of calls, but we recognize that the calls have been very supportive for, I mean, in terms of those who have had COVID-19 and they've been doing these calls with us, we've seen them go through some of the most difficult times and we've helped them to advocate for themselves in situations where they didn't really feel like they had agency, especially in terms of employment, which is something I think we need to really think about as we start opening up the states, because having individuals who potentially have to disclose their COVID-19 status or not delay their return back to work, there's all kinds of implications for that. And we're seeing it live and in color happening even, before states are opening up. And so the calls have been just really social support for those in our network. And we've done them within Black Ladies in Public Health, but also some that are just public and available to anyone.
All right. Well, again, that gives us more of a background with what you're doing there with the having those check-ins. And Dr. Edwards, you mentioned a piece about worker commitment. Can you just sort of emphasize that a little bit more?
Sure. Do you mean the worker safety piece or relating to burnout?
Related to burnout, I believe that's what I have noted here. Yes, related.
Sure, absolutely. So what we're seeing first and foremost under even normal circumstances is that stress is the #1 reason that people take off from work for sick leave. And so now we're in these even more strenuous times. And we really have to be mindful of individuals that are being overworked. A lot of our nurses right now are being overworked. Our physicians are being overworked. And I hesitate to name specific positions because there are so many frontline workers that are at capacity right now. And so the work I do is particularly in supporting women, but relating to burnout and helping them to come back from a state of burnout into balance, because it takes a while to get there, or it takes strenuous circumstances to get there. And so I partner with women and just speak with them about what the experience is like and specific tools and strategies for them to recalibrate, which is going to be so important once this is all over. Not only, doing that data work and the collaborative work, but ensuring that the collective mental health of our health professionals is where it should be is also going to be very important.
And thank you, Dr. Edwards. Dean Lyn, quick question. Our Governor Kemp, your thoughts?
That was a question, huh? I think it's fair to say that I wouldn't be alone in saying that the data in Georgia does not support a reopening of the state in the way that has been announced, and President Trump himself has said that. So that says something. I think that there's a lot of factors that politicians weigh in making their decisions, and I can't speculate about what those were, for Governor Kemp. All I can say is that, for the most part, the public health community and many others, Keisha Lance Bottoms, the mayor, and others across the state have, come out and said that they, strongly disagree with the approach that the governor is taking. At Georgia State, what we do is really focus on, our students our faculty and our staff. As a school of public health, we also really try to get the message out about what the right behaviors are, how to keep yourself safe, regardless of what the governor or a local city or a county is doing. What are the things that you need to do to really make sure that you keep yourself and your family safe? So we are a state institution, and so we follow the directives of the governor and the chancellor. We operate within that and try to do the best we can for our students.
All right, wonderful. Well, again, we're patient with our governor, and again, it's really one of those things that from the public health side, it's just not the best decision. But we know from the economic side and the political side, it may be somewhat expedient to get Georgia back on track, if you will. But again, it's maybe at the sacrifice of some.
Yeah, one of the things that I said early in this process is that we needed to be thoughtful about how long of a shutdown we needed, because one of the things that really struck me early on is that there's going to be a lot of pain, and that pain is not going to be distributed evenly from the shutdown. People that can't work and don't have an income, and what's the trickle down from that? So I'm certainly not defending the governor's decision, but I am saying we couldn't stay shut down forever. If it was me, it probably would go for another month, 3 weeks to a month, but I'd be really following the data and sort of the 14-day consistent decline in infection we just haven't seen in Georgia yet. And I think maybe in 3 weeks, 3 or 4 weeks, we would probably be there. But we are where we are, and we'll have to find a way to manage.
Mm-hmm. Right. Yeah. All right. So I want to open the floor again. Again, we want to honor what we do every time by allowing the attendees to ask any questions of the panelists. Is there anyone that has a question that they'd like to present to anyone on the panel? Anyone attendees, all you have to do is raise your hand. I will unmute you. Can we get a check-in from where people are? If you don't mind, just put in the chat box. Just let us know where you are, what city and state you're in, so we can get a feel for where everyone is. And does anyone have a question? For the panelists, let me ask another. Okay, Dr. Harris, let me unmute you.
Thank you.
Okay, yes, Dr. Harris, go right ahead.
Very much. Thank you very much to the panelists. This is very interesting listening to your presentations from the different states. Dr. Lyn, I'd like to ask you a question. Yes, I think we all sort of hesitate with Georgia opening up and recognize that 3 to 4 weeks might be actually a good thing, but we don't have the luxury of that. So I'm just wondering, one of the very important strategies, the most important strategies that's been talked about is social physical distancing. Where do you see that, or do you see that happening to the extent that people will be protected as much as they can? And we understand that there are areas where they really need, protective gear, PPEs, and that sort of thing. But in the general public, do you see a response where people recognize that this is still a pandemic that's spreading quite seriously across the state?
It's a good question. I think there's going to be some variability in how people respond. I mean, I can tell you in one of the communities that we work in, where there's a large proportion of immigrants and refugees, the behaviors that we've noticed, it was as if nothing was going on. And there's one story where a local clinic tested someone, got the result, found they were positive, went to their home, couldn't get them on the phone. They were there, they informed them they were positive, and left to get some groceries because the person said, I need groceries. And they said, no, you can't go to the grocery store. I'll go for you and bring it back. When they got back, the person wasn't even there, had left, and so, quarantining oneself, self-isolation, understanding the risk, using a mask, all of these are things that some of us take for granted that everyone understands. But if English isn't your first language, if you don't have that same access to technology to understand what's going on, you're at a disadvantage. And so, you know, I think there is a variability. There are other people who just don't believe that this is real, you know, and that it's a conspiracy of some sort. So I think there is variability, but I think by and large, social distancing has and will be a strategy that helps us to overcome this virus. So I expect that to continue. I mean, we're looking at on campus as we think about bringing people back to campus in the fall. Okay, we have a lecture hall that holds 200 people. We've actually measured how many people can fit in here with social distancing, and it's 45 people. So does that mean now you got to break this up into multiple classes, or do you rotate the students in? Some come this week and some are online. So there are a lot of things that we're trying to work through to understand, to figure out what our plan is going to be going forward. But I don't think there's any question that social distancing is an important strategy and element of a larger comprehensive approach.
Right. Sorry, just a follow-up question. You talked about the immigrant man who left the house. Is there an issue of stigma at all associated with coronavirus where you are?
It's a good question. Yeah. Initially, with the Asian community, there was definitely stigma and discrimination, I think is even fair to say. And we had a number of op-eds that came out in the Atlanta area dealing with that. Actually, one of them, I think, was a national piece. So, you know, that is going on. If you have or had COVID-19, how do you feel about that? I don't know. I haven't seen reports on that in terms of whether or not people, you know, openly disclose that as a point of pride, or, you know, that they survived, or if it's something that people hide. I would love to see some studies on that, but I haven't seen any at this point.
To that point, I do want to mention that one of the things that we were discussing as a group was the employment ads, job offers on like Indeed.com that will say they needed to have in the description it would say, you know, they have to have had COVID-19 already. So we are seeing where employers are specifically looking for people who have had COVID-19. Not really sure if with all of that's coming out about the possibility of being reinfected and all of these things, I don't know exactly if those are based on the science at this point, but perhaps just, you know, thinking about viruses in general. But that's something we are seeing. And I actually had a recent encounter with my brother who drove down from Chicago to Texas to visit. And I was like, oh, wow, you just pop up. And so as we were talking, one of the things that he said was, I'm a vegetarian. I take care of myself. I'm clean. I'm not a dirty person. So I don't understand what's the problem. And I tried to explain about the surfaces and things like that. And one of the things he mentioned is in Chicago, because we live on the South Side, he said in Chicago, if you go to the doctor, they don't even have to test you. They'll tell you you have COVID-19 or coronavirus. And I said, well, that's not true. He said, well, yeah, it is true. If you go, that's what happens. And it reminded me of a video that we did see recently where someone had gone to the doctor, they had all the symptoms, they didn't get tested, but they did get a paper with the diagnosis. And apparently, you know, that was something that fueled a lot of anxiety, anger. They went on to social media and pretty much it went viral. And one of the things I tried to explain is, although that might be a standard practice for something like this, and that was kind of the conversation, whether or not it being a standard practice or a practice because of certain circumstances, if that's still enough, do we owe it to those patients to at least explain to them why not testing them would lead to, you know, without testing them, how this would be a diagnosis. Taking the time to really have conversations where the patients aren't walking away feeling angry or, you know, disgruntled or ignored or what have you, which we're seeing a lot of in terms of some of these deaths now. So I do think there is a lot of there's an undercurrent of stigma that's happening that perhaps we do need to be more get more information from the communities themselves. But via social media, there's a lot of speaking out about different situations. So I do want to make that known.
Okay, well, two things. Tara Robinson, we're going to get to you in a second, but I unmuted Dr. Tracy Nelson. Dr. Nelson is an OBGYN, as we just talked about physicians. Obviously, that's been brought up. Again, Tracy, again, triple Ivy League, Dartmouth undergrad, Yale for medical school to Penn for her OBGYN training for her residency. So she's in Myrtle Beach, so we're glad that she's joined us in the past as panelists. And as we're hearing this now, which is news to me, that some people are just automatically diagnosed with COVID-19, as Jasmine just relayed, that's what's going on the south side of Chicago. Tracy, Dr. Nelson, have you heard anything similar to that?
No, I have not. No, I have not. So there is an opportunity here to be tested, but you have to call an 800 number and demonstrate that you have symptoms, and then you can drive through and get tested. I'm not sure who's paying for it, but as far as just giving that diagnosis without testing, no, I haven't heard it.
And that is rather strange. Okay.
That is rather, is that for unemployment, or is there some kind of benefit, or is there some kind of secondary gain for the person who is giving the diagnosis? Do they get more money from the government or something?
Well, all of those theories are out there, but one of the things I think we do need to talk to a lot of these individuals who are going public with these diagnoses without testing situations. I'm not exactly sure those individuals, I don't know them personally, but what I asked my brother about, was the, what does he consider testing? What exactly did he think that should happen when they're getting tested? And he didn't really know enough about the individuals, their experiences in the care of the physician. So I think that that's where we need to really do some more digging and understanding of, getting understanding of what's happening during those experiences. So I'm not really sure.
Can I follow up with another question and kind of pose this to the panelists? There was a man in New York on NPR who said that he is afraid that this COVID is going to become a Black disease, and it will lose some interest, I guess, with the mainstream community, and doesn't want to be stigmatized because he feels like if it becomes a Black disease, then there won't be as much interest and as much research, as much money. And I'm thinking this disease has kind of demonstrated all the disparities in healthcare and the wide gap and the reason for the wide gap. So my question is, what do we do next? Like when AIDS came out, and that was a sexually transmitted disease, so it just wasn't droplets. So I had possibly a lot more restrictions. What do we do as a community? Do we do what the homosexual community did? And they became activists, and they really advocated on their behalf to make sure that would be research and there would be money and there would be treatment for a disease that had a lot of stigma because it was, mostly transmitted sexually. Are we going to kind of become active in that same way and try to make some corrections in the disparities in healthcare?
All right, Tracy, thank you for that question. I want the panelists to address that, and then Tara Robinson, you have a question, we're going to get to you. So any panelist who wants to grab it, please do.
Sure. Can I jump in and say that's a really important, critical question, and we have to, in my opinion, hopefully factually address the issue so that it's still clear that COVID-19 affects everyone. And then unfortunately, in this emergency situation, we're seeing the same inequities play out that we see for cancer or that we saw for Hurricane Katrina, for example. And so unfortunately, everything is compressed because we are in this, public health preparedness state right now. But as far as the data goes, about half of cases are even collecting race right now. But of those half, we are seeing those disparities in terms of African Americans as well as, Latinos. It's not just the African American population. And then we can also consider an opportunity to really address the full continuum of care, as I mentioned before, where we're seeing disparities in testing. We're seeing disparities in hospitalization, where African Americans are not the most often diagnosed groups. There are a higher percentage of the white population or Caucasian population that are diagnosed with COVID, but hospitalization-wise, there are disparities there. And then, of course, the morbidity and mortality disparities that Dr. Ward has done a great job of pointing out. So if we can figure out a way to concisely tell the story, then we'll be in good shape. But we're not the ones getting diagnosed the most often. And that's what makes the disparities so troubling, because that's not the story that the death rate tells.
And I think Tracy is also saying that, how do we get in front of it in the event that it is possibly going to be associated with the African American community? Again, how do we organize and just possibly prepare in the event that this is just going to be sort of tossed upon us? And again, you just got to be very clear in saying that we know what's going on with the testing, with the disparities in the testing, with the disparities in the reporting. And again, it is a matter of, again, how do we stay in front of it, make sure we understand that, again, this, there's no prejudice with coronavirus, but, the gentleman in New York, he said he feels as though it's going to be, sort of heaped upon our race. How do we make sure that we get the right messaging to say that, no, it is not a Black disease? But still in doing so, we need to organize to make sure that we're able to do just that. I want to let Tara Robinson ask a question. She's been waiting for a while. So Tara, I will unmute you. Can you ask your question, please?
My question is, before COVID, we were already having these conversations around heart disease, cancer, about disparities and biases in care, etc. I think we keep expecting the current system to do us justice when we already know that it won't. So when we come out of this, for the organizations that are boots on the ground that don't get funding, how do we create our own system so when COVID or another big thing happens, we're prepared? And I think as we go forward, that's the approach that we need to be taking, is creating our own systems of care so that this won't derail us again.
One of the things, Black Ladies in Public Health, and I work directly, she's in Arlington, Texas, Grand Prairie, Texas, right? So we work together a lot. One of the things so thank you for joining the call. We were talking about, we had a policy call, and one of the things we were discussing is creating self-sustaining organizations that don't necessarily need to depend on funding from the government specifically to really start to train, like we think about promotores in the Texas area, community health workers who are really coming up with solutions. When we think about right now what communities are doing, a lot of them are relying on what they already know. Despite the fact that we're on these, Zoom calls and on social media, we have all these different health communication strategies, some people just are not following that, and that's because of various reasons. My mother works all day long, so by the time she gets home, she doesn't have time to follow up with all the new things that have happened with coronavirus. And same for a lot of people who are just not even digitally connected to all this information that's coming out so quickly. So we have to think about ways that we are really promoting these community health worker programs. But we also need to think about having those that are culturally specific. And that's why I mentioned the promotores in Texas, because that has been a really wonderful model for reaching communities that are typically not going to allow Georgia State or Black Ladies in Public Health or, Morehouse, any of these schools, even no matter how, culturally relevant they might be to the more privileged folks that are able to attend them, it's still, still need to have community buy-in and support. And they really are coming up with their own solutions to their own problems. And that is the greatest thing, but also the scariest thing that's happening right now. And I think we have to deal with that.
Carl, did that address your question?
Yeah, it did, and I come from a survivor's perspective. So, you know, just going into the next season, I just want to make sure once we come out of COVID that, you know, we have something in place different than what we currently have now.
Okay. All right. Any other panelists want to address Tara's concern, her question?
I'll say a couple words, and I think this may get back to one of the earlier questions as well. It strikes me that, you know, one of the differences to some extent is how easily between HIV and COVID is how easily it's transmitted and that you can become infected. And we haven't seen in this country the type of action that has been taken to protect the public. And, you know, when everyone feels at risk, all of a sudden we're doing things that many of us have been calling for a long time. Doing away with co-pays. If you want to get seen for, you know, COVID-19 or symptoms, no charge. Care, no charge. If you need paid sick leave, oh, we'll do that too, because we don't want you coming to work sick. If you have to take care of someone in your family that's sick, we'll pay you for that too. All of these are things that many people have been saying for many, many years are fundamentals, building blocks of a healthy, strong society. But we have not found the political will to implement those kinds of things nationwide. One of the things that I think in terms of vulnerability is that I think we need to be, there's a great article in Health Affairs this week talking about the use of data to identify vulnerable populations and target and support vulnerable populations. One example they used, it was a case study on using voter registration information, which gives you where a person lives, their age, you know, a variety of information, as well as overlaying that with census data. So you can identify buildings, as an example, in an urban area that have a high population of high-risk individuals. So those are the kinds of things I think we need to be doing on targeting. On testing, you know, we're seeing more drive-through testing. What if I don't have a car? You know, I mean, how are we ensuring that there's equity and access to testing? And the last thing I'll say is, you know, we've, in this country, given payments to everyone under a certain income bracket, and that's a good thing. But I think when it comes to families that are losing their family members to this disease, it seems to me that the government could make additional payments there, because the loss that those families and communities are going through and suffering through will have exponential impact on those communities, the African American community as an example. And you know, when there are other tragedies, we support, you know, the government supports individuals and families and make sure they have what they need. And I think that's needed here as well. So I'll stop there.
Dr. Edwards, would you want to say anything? You want to add anything to that?
You know, I would just say a core takeaway would be that the hospitalizations are going to tell a story because they bridge the risk with the outcome. And so I'm definitely going to be paying attention to that hospitalization information. And recovery will take time. I believe once this is all over, there's going to be a lot of reflection of the workers, of the clinicians who have been through a lot, and they will have to recover emotionally and mentally, and there could be repercussions for the lack of protection that they have had to endure and still deliver care, you know. And then I would also just say that my hope is that COVID-19 doesn't become stigmatized, and unfortunately, due to the mode of transmission relating to HIV and AIDS, that even worsen the stigmatization. And so, you know, mode of transmission might ease that stigmatization effect in this case. That doesn't make it right, but hopefully we can craft a narrative that keeps everyone engaged and also highlights the inequities that are taking place.
And again, I want to thank you, Dr. Evans. I want to underscore what Dean Lyn just mentioned, because he really said a mouthful. I mean, when we look at FEMA and how FEMA is there to address, disasters afterwards, being able to, pay these families and pay for whatever took place in that particular community to individuals. We know there were payouts after every sort of national disaster. We have actually someone who's on, who's in our session with us this evening. He goes out for FEMA, and that is what his job is. But again, that would be quite the arduous task to push that type of legislation through to say, okay, for those who, families who suffered from this COVID-19 death, how is it that they can, get payment for the loss of their loved one? How do you put a price tag on that? Again, I think that's very commendable, and we really need to explore. And hopefully we'll have the political will to want to do that, because obviously we're going to see the type of economic devastation that's going to come as a result of for families who had to deal with that type of transition. So with that, as we get ready to close out, Dr. Harris we have 5 more minutes, so we'll let Dr. Harris make a point. Yes.
Just a quick comment. I think there's one thing to think about those who've lost a loved one. I think what we're hearing also is the long-term effects of COVID on the individual. So there might be families where that individual can no longer work, or who cannot work for an extended period. So I think we need to have to think about those families also. But I did take the point that we need to think about families who've lost a loved one, but certainly families who are going to lose income because somebody's not able to work in the long term.
Very good point. Very good point.
I'm sorry, I just wanted to mention as well, one of the things that we need to start thinking about as we are entering into a very clear point in our recovery process is thinking about the clinical trials. We have over 500 plus clinical trials globally. 300 are currently actively recruiting people globally, but in the United States we have about 100, and we can find those clinical trials on clinicaltrials.gov, I believe. One of the things I noticed is that we have to really think about how are these community boards, sort of what we see in other diseases, how are they being formed? How are people being informed about the process of participating, maybe joining calls that are open to the public? We need that information for the public, because we have community folks who want to be a part of this process and have voices heard throughout the entire spectrum of this disease. And I don't necessarily know that people are really welcoming to community people in that space as it relates to managing these clinical trials. And so I think if there's room to provide me with some support, I would love to have that, because I have been asked several times about that process.
We have 3 minutes. I want to take some closing remarks. Dr. Ward, do you have anything else? Then we'll go to Dr. Edwards, and then we'll close out with Dean Lyn. Dr. Ward, anything else? Again, we have 3 minutes.
No, thank you.
Okay.
This is great.
Okay, wonderful. And make sure you put your contact information. If we don't have your email address, please put your contact information in the chat. Send it, put it there. You can send it privately either way, so it can be on our email list when we go live. Dr. Edwards, please, closing remarks.
Sure, thanks for having me on and being part of this important conversation. I just want us to be mindful that the CDC is really the authority on this, and even the research team at the NIH as well, and to hopefully follow their guidance. And I'd love to talk more and continue the conversation anytime. I'll put my social media handle in the comments, and thank you all for coming.
Thank you, Dr. Edwards. Dean Lyn.
Yeah, I think one of the concerns that I have is that this, what I'll call one-time social distancing, may lead to, once we come out of this, another wave that hits us in the winter ahead. And I think there's a lot of people that are concerned about that. I think we've got to move from where we are right now in terms of these what are called blunt instruments to manage contact between people, how do we open society back up, but do it in a way that, you know, allows for an equal or better level of prevention. I think that's a challenge in front of us at the moment. I think we got to ensure that the resources that our communities need are there. There are things that we can do, but I think we're all hoping that some therapeutics emerge because that may come before a vaccine comes. So, you know, being able to treat and support those that are infected is going to be important going forward. We're, you know, working to ramp up contact tracing. And so there are all these pieces. I mean, we may have universal, sort of everyone has to wear a mask, those sorts of things. But we've got to come up with an approach that allows for safety and prevention because this may be with us for another 12 months or more.
Again, very wise words, Dean Lyn. We want to thank all of our panelists, Dr. Edwards, Dr. Ward, for being with us this evening. Thank all the attendees. A great conversation this evening. We'll be back in 48 hours, 47 hours. We'll be back Thursday again. Dr. Muriel Harris, who's with us this evening, will be back on a Thursday. Again, she's going to be giving her perspective on what is going on in the Louisville area. We'll also have a position from the Sacramento area. Then we'll have Dr. Augusta Stevens, who's an ophthalmologist here in Atlanta. We had somebody who's early for the next session. I guess they may have gotten the hour confused because he just joined, but it's like that sometimes. But we want to thank everyone for being here. As always, stay safe, stay healthy, and stay home. And we look forward to seeing you again in 47 hours right here on the Empower Hour. Thank you so much, everyone. Have a wonderful evening.
Good night. Thank so much.
Thank you.
You're welcome.